Hi, everyone. My name is Katie Cacchiani. I am the Senior Marketing Manager at Illume Fertility. And I'm really excited to host this live virtual conversation with my doctors who I absolutely love and admire. And I feel very grateful to have them both on my team. And so I will kind of have my my OBGYN, Dr. Gofrani, kind of introduce herself, and then Dr. Hurwitz, you can kind of give a little intro as well.
Hi, everyone. I am Shieva Gofrany. Most people call me Shiva, not Dr. Gofrani, as I joke, because if I'm Dr. Gofrani, then I have to behave more maturely. And Katie and Josh know that I only want to behave so mature. I will be very mature when you need me in the operating room, like that. Otherwise, I want to pretend I'm young. I've been in Stanford for 23 years. So I've been a doctor since 1999. And, you know, like everything in life, as I joke, it's miserable and magical. It's a wonderful field. I love it. We are so lucky to have a great patient population, and yet it's exhausting and stressful and anxiety provoking, you know, COVID notwithstanding. I'm really, I feel blessed and lucky that we have good specialists around us. So while I think that my knowledge is broad enough, I don't need to know so much about fertility because I have specialists like Dr. Hurwitz and everyone at Illume. And that's actually so valuable to me because I can very easily say to my patients, if we have any trouble, or even if it's just going to make you feel better, I can send you off, which is not the case for many people in rural areas. So if you are coming to us on the Zoom from a rural area, there are ways for you to get help. And so we can help connect you with other physicians that can do consults and things like that. We are lucky in this area because we have everyone. And on top of it, I myself have had 3 babies and 6 miscarriages and a vaginal delivery and 2 C-sections. That's like the beginning of the laundry list. And that's just the obstetric part of it. So I feel like it's really helped inform me about how to talk about all of this stuff: fertility, infertility, getting pregnant, staying pregnant, birthing, everything. And it's as Katie and I talked about before you jumped on, Josh, it is a lot to go through as women. So I'm glad that we're going to try to keep opening these discussions so that we can debunk a lot of the myths and make it less esoteric and less mysterious and less anxiety provoking. So thank you.
Yeah.
Wow. Well said, Shiva. How do you follow that, Katie? So Shiva's my awesome, fun, fierce friend. And actually, you're one of the very first people I met here when I moved to Connecticut in 2006. And I've always said to anyone who ever asked that when I graduated fellowship and moved here to Stanford, to Norwalk in RMA, Connecticut, now Illume Fertility, this is the only job I've ever had in my whole life. I graduated fellowship, I joined RMA Connecticut, now Illume Fertility. I literally have never had another job. And I'm so proud of that and so happy about it, that it's worked out. And part of the reason why is amazing patients like Katie and all of our other patients at Illume Fertility, and also our amazing colleagues in the OBGYN community who really welcomed me with open arms and became really close friends like me and Shiva, and Charlie, of course. And it's really been an honor and a privilege to work alongside you for all these times, and just fun sharing patients back and forth. As Shiva and I used to like to say all the time when we do these together, we like to yenta it up together. We like to chat. We like to have fun. We like to do it together. And it's all for patients' best interests that have such a strong relationship, I think. And that's where I think that was the nucleus of this talk. I think, as far as I know, this is the first of its kind talking about the transition of a patient from a fertility clinic back to her OBGYN. And I'm just really excited to kind of get this knowledge out there and talk it over with you, Shiva.
Yeah, good. Well, thanks for having me.
Absolutely. And, you know, just as a fertility patient, only a few weeks from delivering my IVF baby number 2, I've been, you know, part of this transition from fertility clinic to OBGYN twice now, obviously. And to your point, Dr. Hurwitz, like it definitely has some anxiety and some emotions that come along with graduating for, you know, Illume Fertility, where, you know, you're monitored so closely. You know, you're on all these different meds. You have this very, you know, personal protocol that you're following, and this patient care team. And then you're kind of like released to the wild in a way. And, you know, you find yourself at your first OBGYN appointment. And I remember both times sitting in the waiting room and I'm like, I'm just like a regular patient here. Like, you know, there's no difference between me and, you know, the person next to me, as far as I know. And you just kind of feel a lot of feelings with that. So yeah, I think that it's a great topic that we should talk about. It's not discussed enough, I think. So yeah, I'm really excited to be here with both of you. And so I guess we can kind of start off with like we've gotten a few questions through our question box on Instagram, and that have come up in just, conversations with patients at Illume, and questions even that I've had when I've transitioned to the OBGYN. So I guess the first question is, when do patients make the transition from fertility clinic back to the OB, and why at that point?
Shiva, I'm going to jump in here if that's okay.
Please, yeah.
So I think that we're very well equipped to watch the first trimester, especially the early first trimester, with a lot of detail. I always tell people I'm a first trimester doctor. I don't know about anything else after that, right? So we do like to watch carefully to, number one, make sure that you are in fact pregnant, that you have a viable pregnancy, and that all the pregnancies are in the right place at the right time, right? Because there can be mishaps along the way, and we just want attention to detail, make sure we're not missing anything, and everything's diagnosed appropriately and locked down. We also want to make sure, especially in fertility treatment cycles, that estrogen and progesterone levels are being supported alongside the pregnancy. And then we look for certain growth markers that are only really apparent in the early, like maybe the first 2/3 of the first trimester. So that's one of the reasons why we're just so detail oriented in our office, more so than maybe when you get out farther in pregnancy. You might not need that kind of detail and watchfulness. In my mind, a good time to transition, right, is after the pregnancy is established in the right place, after a strong heartbeat has been established, and after we've seen a couple of ultrasounds where we know that when we connect the dots and see the growth curves, that everything's matching up the way it should. That typically happens somewhere between 8 and 10 weeks. All right. Some types of cycles we feel more comfortable, like a spontaneous pregnancy, or maybe a less advanced treatment cycle, such as an IUI cycle, maybe a little bit earlier, maybe 8.5 weeks. For IVF cycles, we like to supplement progesterone and estrogen supplementation until the end of the 9th week. At that point, the placenta has fully taken over, probably a little bit before then, but we like to argue on the side of caution, where we call what's called the luteal placental shift, where the pregnancy is no longer dependent on estrogen and progesterone secreted by the ovaries or that we give them. And it is now fully taken over by the placenta. That usually happens between about 8.5 and 9 weeks. We like to err on the side of caution and give that an extra week, especially in IVF cycles. So that's usually why the transition's between 8 and 10 weeks. Doesn't mean you can't get discharged sooner in some special circumstances, but that's where we feel comfortable.
Yeah. Well, and most people don't want to be transferred sooner, right? I think to your point, Katie,
right.
It's funny when you say you sit in the waiting room thinking, oh, I'm like everyone else. And I think that one would think there would be a group of women who would say, oh my God, finally, I don't need all these appointments and I get to just be like everyone else. And we all may know this, but I'll reiterate for the group who are watching that the American College of OBGYN, the guidelines would say you come every 4 weeks until 26 to 28 weeks, and then every 2 weeks after that. But as I say to every fertility patient when they walk in the door, I know you're coming from a high touch situation where you have been there once or twice a week, being watched carefully. And so if you are happy to have less intervention, by all means, we'll let you do the routine, which is come and see us, at 8 weeks and then 12 weeks and then 16. But I would honestly guess that 98 to 99% of our patients are like, oh no. And I always kind of open with, you can come to our office every single week if you want. But I want to be cautious in saying that, especially because the group who are watching this are not only patients of our practice. If you are in another part of the city, the state, the country, where your general OBGYN says to you, you came from the fertility group, everything looks great, we can treat you like everyone else, you don't need to come more frequently, it doesn't mean that your doctor doesn't care or doesn't know or doesn't anything. It merely means they're following evidence-based guidelines, which is really valuable, right? Evidence-based medicine is something we all should be doing. There's the secondary part of it, which is that I myself think that evidence is excellent and important, but there's an emotional side of medicine and the art of medicine that cannot be measured by evidence. And so to me and to my practice, offering our patients like, you can come, every week if you want, but I always say and joke, in seriousness though, that I can't have patients coming every week, but then complaining if they wait in the waiting room. So as I always say to patients, as long as you don't get upset when you're waiting in the waiting room, because I can't say yes to every patient and then unfortunately see everyone necessarily on time. So it does become a conundrum. And I can understand why many generalists don't necessarily offer that up. And I really do want patients to know that it's not the right answer to say, come as much as you want, because that's feeding into the anxiety. that said, as someone who went through a lot of the fertility stuff, I understand. Oh, we just lost her. Oh, she'll come back.
Okay. Yeah.
Right, Josh, will come back. But that said, I think it's valuable for anyone out there to kind of understand and know both sides of it, that the routine would say you don't need to come more frequently, but many doctors will leave the door open. And so I think it's good to see both sides of it, right?
Absolutely. And I guess while we wait for Dr. Hurwitz to come back, I'm not sure what happened there. I think so. He did touch on how we are given medication and all these different supplements up until the placenta is fully formed.
Yep.
And I think that's one of the points that I was really worried about was like, I'm doing the progesterone shot every day. I'm, taking estrogen pills, and all of a sudden that stops, right? And I'm like, so are you sure it's okay that I get off medication now? Like,
here you are.
I just had to kick everybody in my house off of all of their streaming devices.
Oh,
yes.
Okay.
Yeah.
Okay.
Yeah.
So what I was saying is, what you touched on, Dr. Hurwitz, was how us as IVF patients, we're going from doing the progesterone shots every day for 10 plus weeks, taking the estrogen pills. I was taking like 5 each day, and then all of a sudden that stops. And I remember both times that when I had made the transition, I'm like, are you sure like I can get off these medications now? Like, it feels so weird, like not having that extra piece of, comfort or assuredness that like, I'm getting all of the things that I need. So I think, you were talking about how at that point, the placenta is completely formed, and that kind of takes over, why we needed those supplements to begin with. So I'm just wondering, is that like a common, question and point of anxiety that other patients get? And is there ever a reason to keep someone on those medications, after that certain point when the placenta is fully formed?
Great question. So fully formed, fully functioning rather than fully formed, right?
Sorry.
Yeah, fully functioning rather than fully formed. So, it's a great question. I do think that people take support in it. I do also think it causes a lot of anxiety between suppositories, oral pills, and shots. So there is both a sense of relief and a sense of support. And I'm sure they're probably opposites on different days, is my guess. I get that question a ton, and I do want to reassure people that once that luteal placental shift happens, once the placenta is fully on board and functioning, you really don't need it anymore. And I could even argue that more might not be better, right? Yeah. And so I do think that whatever emotional support you would get from that is not really born in any medical or scientific thing. And while there is an art and a science, and that's something Shiva and I pride ourselves on, that we support our patients through their journeys and treat them like people and honor their needs, right? I really, as a group, we feel pretty strongly to Illume that you don't need to be on it past 10 weeks. One other issue with another reason why we watch till then is that one of the hardest things that we all have to deal with as a patient, as an REI, as an OBGYN is first trimester miscarriage, right? And that even when everything's looking fantastic and going well, there can be losses. The vast majority of losses are going to happen before 8 weeks of pregnancy. And if we can catch them early and act on them and manage them, I think it's a smoother, better taken care of, right? In the sense that we're with you every step, every minute of every day, and we can kind of intervene early. There's a statistic out there that that if a pregnancy is growing well and has a strong heartbeat at about 8 weeks of pregnancy, that the miscarriage risk comes down by about 75%, right? And if you can get to 12 weeks, it goes down to about 90%. And so we like to help our patients with that transition. That's a reason where the 8 to 10 week thing comes from. But you do ask about support. A lot of people ask to go beyond it. I really don't recommend it. It's unnecessary. And I can think of reasons why you wouldn't want to be on it, even if you get some emotional support from it.
Yeah, I was, I remember I'm like, I have extra pills. I have some extra progesterone, might as well use them up. And you're like, Katie, you don't need them.
Yeah, I actually had that question with 2 patients before I left the office tonight. They needed some help with that. And I called them. Yeah, absolutely.
Katie, someone just asked a question in the chat about, do you get referred to an OBGYN, or do you need to have someone to begin with? So we can all answer that, but you can go ahead and
Yes.
do that. Yeah.
So I will tell you, this is an ironclad rule at almost every fertility center in the world, especially at Illume Fertility, that whichever patient, whatever OBGYN a patient comes with, it's really important that patient goes back to them, right? There's a relationship there that you trusted me to take care of your patient, that we did the job you needed us to do, and now you trust me to send them back to you. So we very strongly believe in not breaking that relationship. I think it's extremely important. Now, people sometimes are unaffiliated, right? And then I ask them, hey, what are you looking for in a doctor? What hospital are you looking to deliver in? Where do you live? Things like that. And I come up with a good match for them, what I think personally and professionally is a good match for them, right? But I think that it is really important for patients to go back to their original OBGYN that they came in with, right? Now, if there's interpersonal problems, that's a whole different story, but that's really rare, you know?
Yeah.
Would you agree, Shiva?
Yeah, I mean, I think to reiterate, so if you got, so some patients will self-refer to the fertility doctor, or
Right.
they'll be referred by their friend, or they've moved into the state. And so they don't have an established relationship with an OBGYN, and then they can ask you for referrals, or they come in. The truth is, though, I might differ from you a little bit. I don't think that everyone has a great relationship with their OBGYN or doctor in general, right? So I think to say like, oh, that's not so common is a little, I don't know how accurate that is. I think that
Okay.
medicine right now is a wonderful field, but it's still a really broken field. And I think finding doctors that people really bond with are hard. And by the way, I don't say this at all to advertise for our practice, because we are very booked. So it's okay. We're not saying to come to us, but I do think, and I say this to women all the time, if you don't feel a bond with your doctor, I think the work that you can do is kind of keep going back with like lists of questions where you're like, well, I'm going to tell them what I want. I think rather than that, and I speak from a place of privilege, not everyone has the opportunity to find multiple different doctors that they can meet and see who they bond with. But if you are in that position, I would encourage you to find a doctor that you do like, because it's a long journey. And ideally, you know, I say all the time to our new patients, the ideal is that this pregnancy is just going to be a lot of fun where we can bond and enjoy each other. That's the best case scenario. But the worst case scenario, which actually often happens, is that there are actual medical interventions that are needed, or care that you really want to feel strongly that your doctor is doing the right thing, so that you don't need to question everything, so that you really know that we have your best interests at heart. And I think the best way to do that, to your point, Josh, is to establish care ahead of time with your doctor, so that you feel good going to the fertility specialist and then coming back, right? Yeah. That would be the ideal. We don't live in ideals. I mean, there are many parts of the country where there are not a lot of OBGYNs, and I think that's unfortunately increasing as OBGYN care changes. But I think most doctors have good hearts and they mean to do the right thing. So I think you can find them.
Yeah.
Absolutely. I also tell people, if they're thinking about switching doctors, to be upfront with their original doctor. Hey, say, listen, just want to let you know, nothing personal. This isn't working for me. This is what I'm looking for. I'm going somewhere else. I actually ask people to do that if they try to switch physicians. I do think that that's what I would like. If someone left me, you know, I would say, hey, listen, just tell me, you know, I'm your biggest cheerleader wherever you go. Just tell me what's going on.
Yep.
Yeah.
That's great. Yeah. And I guess kind of on that same thread, how does the fertility clinic communicate with the OBGYN, you know, once that transition is made? I mean, I know that we obviously, you know, send our medical records over to, you know, the OBGYN, but are there any other points of communication, you know, when you are transitioning from, you know, fertility clinic to OB, just to make sure that, you know, everything's addressed and, you know, nothing is missed, you know, because obviously the first trimester, there's a lot of, you know, crucial things that happen there. So just wondering how that communication works and what you would talk about.
I can't wait to hear what Shiva's going to say about this, because I'll tell you what it looks like from our side of the, you know, you're looking at the same window from opposite sides. I see it this way, you see it that way, and we probably see different things, right? So I'm very interested in this to hear what you have to say, Shiva. But it is important that there's a smooth and tight transition between offices, right? Because you don't want any kind of disconnect in the care. So I think that these are the important things we do, and I hope that you feel them on your side, Shiva. So the number one thing we do is, you know, patients are educated about everything they're doing. So that's number one, they can be their own advocates. Number two, when they graduate, we give them an actual packet of information, a printed out piece of packet of paper that has a worksheet on top that's like what they did what type of treatment they did and everything like that, and sort of the medicines they might be on, due dates, singletons, anything special about genetics, things like that. Underneath that will be the genetic packet themselves, along with the consult from our genetic counselor, which I think as medicine moves more and more to genetic medicine as being important, I think that's really the most important thing. And then we put in there the what we call pre-conceptual blood work, what you might call prenatal blood work, but general health stuff that you need to be checked in for pregnancy. So we put that together in a pamphlet. We also include a written report of the last ultrasound they had with us. Give it to the patients. I say, when you meet with your OBGYN, you physically give this to the office. This is what they need to get you started. But then I also send a formal letter back to that doctor, reintroducing that patient to their care. And I think that both of those things work.
Yes. I mean, I'll echo everything you say. I will tell you what I love is I love that not only when they bring the packet, I love that they bring the packet. We are in a world where in theory, like, oh, it's not so good to transmit it electronically, but everyone has different EMRs. Our practice are dinosaurs. We don't even do EMR. If you try to fax it, it gets lost. So I love when patients bring it themselves. I actually would encourage patients across the country to make a copy of it and keep the entire copy for themselves as well, because you might move and it's just valuable information to have. I love that besides the medication that was used and things in the labs, in your group, you do have that letter that tells us the due date, that it's a single baby, that, you know, all the really important things in a quick form, because we're trying to meet the patient, bring in information, do everything. And so seeing it concisely helps. I also think it's really valuable for women to understand what tests they've had. And by and large, I find that your patients are very educated. They know that they've had the genetic test and what genetic tests they've had. And I think it's good for everyone to know, and I'm assuming every fertility group does this across the country, there are occasionally patients who have more complicated backgrounds than kind of the more straightforward, I had IVF, I had a transfer, I have a pregnancy, you know, I'm on certain standard medications. And so the doctors will often call us and say, I'm sending you this patient, just FYI, I want you to know a little bit about her background verbally so that you understand the context. So the good news is I think any fertility group throughout the country would do that with the generalists there. The other good news is this. Let's say none of that happened and all I got was a bunch of blood tests. It would not make my life as easy in that moment, but just to diffuse any anxiety and fear that, like, you're walking into a doctor's office and they're not going to know what to do. If you just walked in and I knew nothing about how you got pregnant, kind of touching upon your point, Katie, that once you're in the waiting room and you're sitting next to someone, the honest answer is you do need a couple extra tests during your pregnancy if you go through IVF, certain specific ultrasounds that we can talk about. But outside of those, once you're pregnant, yes, you have, again, a little bit extra risk of a little bit extra things, but you don't actually need to be treated that differently. So the good news for anyone out there who is anxious and worried that all the information is not getting transmitted is that your general OBGYN will still be able to handle what is going on. I still think it's nicer, like we said, when we all have information, but I'm so glad to be able to comfort people by saying, you know, even if we get that information 2 days later, it's going to be okay.
Yeah.
Right.
Yeah.
Think about how far ahead of the game you are when you show up with a packet or just the knowledge, right? Than someone who shows up for their first, the first pregnancy appointment, didn't know they were pregnant. You don't know how far along they are. You know what their dates are, their due date, whether they have one or two, one or two singleton or twins, and genetics, right? They're already pregnant. If there's a genetic problem, now we have a problem rather than preventing it ahead of time.
Yep.
So very much ahead of the game. I think all of our patients should take a lot of solace in that.
Yes. And actually someone's comment here was something I wanted to touch upon, which is great. When I send people to you guys, what I actually say is the minute you find out you're pregnant, call our office and make your appointment for your new OB visit, which again, standardly, let's say a new OB visit, if you just came in fresh, would be around 8 weeks. And again, at Illume and most fertility practices, you'll send them back and I jokingly say the same thing you do, Katie, you're going back into the wild somewhere between 8 and 10 weeks. But again, let's say you get, graduate and released at 9 weeks, and all of a sudden you kind of want to be seen like the next week. Your doctor's office might very well be booked. And so I do think it's good to think ahead by maybe 2, 3, 4 weeks. Ideally, you're going to make it to that appointment. And if God forbid something changes, you can always cancel it. So I would personally say call ahead. I don't know that every practice will accept you to make that appointment, but I think many will, because we'd rather you have the spot than kind of try to scramble and squeeze you in.
Yep.
I get that question all the time. When should I make my appointment with my OBGYN? And they can ask me at their first positive pregnancy test. What I always say is once a pregnancy is established, hey, look, you know your due date. Here it is. This is awesome. Yeah. You can call them up. And sometimes these appointments are hard to get. I say, hey, listen, call them up. Say, I know I'm pregnant. I was at Illume. Here's my due date. When do you want to see me? I'm going to be with Illume until like 9 or 10 weeks. When do you want to see me? Would you agree, like between 10 and 12 weeks, you've been watched very carefully so far? Is that a good time?
Yes. And what I was going to say is not only because of the anxiety factor, right, that people want to be watched, but let's remind you that if you've gotten as far as 8 to 10 weeks with a steady heartbeat, you're likely going to continue. But there are 2 important tests that happen around that time. So there's the NIPT, the NIPS test, non-invasive prenatal test, which is a blood test screening tool nowadays that we use, not for everyone, but for anyone who wants it, that helps us tell what the chromosomes are. So it will tell us the sex chromosomes. More importantly, it will rule out, for the most part, things like Down syndrome and other genetic abnormalities, even if you've had in vitro fertilization with pre-implantation genetics. And that test can be done as early as 8 weeks, but we typically do it at 9 or 10 weeks. So it's a good idea to get to see your generalist by about 10 weeks, because that test is a blood test, but it takes 7 to 10 days to come back. And then the second test that's timely and important is the nuchal translucency, which is the ultrasound that measures the fluid behind the baby's neck. And that's done at about 12 weeks and 5 days through 14 weeks and 5 days. So again, it's a good idea to get to see your doctor within that 10 to 12 week stretch.
Yeah. And actually, another question that I feel like we should touch on now, because we're talking about the different tests that happen during pregnancy, is that I know that for IVF patients, maybe all fertility patients, that the echo scan is recommended or highly recommended after the 20-week anatomy scan. So wondering if we can kind of touch upon that and why it's probably, why it is recommended for patients at fertility clinics to do.
Dr. Hurwitz, I'm going to let you take this away. Although I'm going to comment really quick that we have to keep in mind, I don't know how many people are on the panel are from here in Connecticut versus from places that are throughout the country. And it is a fairly new, true recommendation, meaning our patients have been doing it for a long time, but it was a little bit, for lack of a better word, kind of off label. Like it was an abundance of caution, but it wasn't the guidelines specifically according to the American Cardiology Association, or I think ASRM.
SMFM or SMFM. Yeah.
Yeah. And so that has changed. So go ahead, Dr. Hurwitz. You can tell us the good details.
Yeah. So, I mean, the question comes up, are there differences in pregnancies between, let's say, assisted reproductive technologies, which is IVF, that's not IUI or ovulation induction or other things like that, or timed intercourse or things. That's a different type of patient. But in IVF, is there something different about the pregnancies? And it is plausible because these embryos are outside your body for the first 5 days of their life before they go back into your uterus. And is there something different about them? A lot of the data is confounded traditionally going back many years, because in years past, there was a lot of twins in IVF. There really are no twins anymore. It's very rare these days because we always put in one embryo at a time. So it's a little softer now about whether those differences really do exist between IVF singletons and not IVF conceived singletons. But what has stood the test of time, and I think the maternal fetal medicine specialists feel, is that there might be a slight increase in cardiac issues with IVF babies. And I think that it's in flux, because while it is a formal recommendation from the Society of Maternal Fetal Medicine Specialists right now, there's been recent publications from the original group at Yale that said there was a problem, that there isn't a problem. So it's a little bit in flux, but I think that as abundance of caution, why not get a special echocardiogram, which is just an ultrasound on you, and that looks at the baby's heart very carefully. So I think that's where we are. And I think most MFMs would say that, but I think also at the same time, they would also say that the data is sometimes outdated and sometimes inconclusive, but if it can't hurt and it might help, kind of why not? Right. And I'm going to steal your thunder and your line here, Shiva, because I've totally taken this line for you. It's sort of proactive, not paranoid. Right.
Correct.
And yeah,
good.
That's my favorite phrase that you said. Proactive, not paranoid.
But here's where I do really want to remind myself and all of us not to be, I don't know what other word to use, but again, privileged or ableist, because we do practice in a very urban area where we have access to a lot of maternal fetal medicine doctors, which for the rest of the world to know, maternal fetal medicine is the same as saying perinatologist, is the same as saying a high risk OB doctor. So I have 2 at my fingertips in my area. So I can say, of course, go get an echo. And just for everyone to know, what Dr. Hurwitz said in like real speak is, if you had in vitro fertilization, there's a slight increased risk of cardiac abnormalities, right? Very unlikely.
Doesn't mean serious. Could be minor to, could be mild, minor, or severe.
Also true just in the general population and everything. If you've had ovulation induction with medication, like oral medication or injections, that is not the case. So to answer your question, Katie, it's not everybody, it's just in vitro fertilization. Standardly throughout the world, women will have an ultrasound between 18 to 20 weeks for the general anatomy, to look at all the anatomy. And that will either be in your general OBGYN's office or at a perinatology office, or even in a regular radiology department, depending on where you are throughout the country. Again, we are privileged here to have sub specialists. The echocardiogram, which is the special ultrasound of just the baby's heart, is traditionally done around 22 weeks. And again, might be done in a cardiology office, might be done in an MFM office, might be done, again, in a radiology department. There will be people throughout the country who don't have easy, ready access. They've had to travel for their fertility treatment. They've had to travel hours at a time. And so to kind of go back at 22 weeks just for another ultrasound can be challenging. So while if it was my sister and she were living in a rural area, I would still say, please do it just to make me feel better. But the odds are very, very small. And to Josh's point, we're not even sure if the data is really going to continue to encourage it. But for now, that is the recommendation.
Yeah.
And we should be proactive, but not paranoid.
Yes, definitely.
Yeah. I've totally stolen that line, and I quote you when I say it, by the way. Yeah.
Thank you.
Yeah.
Yeah, I see we do have a couple questions that came in while we were chatting about that. So one of them is, should any other extra tests be done with an IVF baby after birth?
Okay. Well, Josh, why don't you answer first, and then I'll answer what we do in the real world.
So after birth, that's a great question. I don't know too many other special things after birth. I think if the pregnancy goes well and growth goes well and the echocardiogram as well and anatomy scans throughout are not only good, but consistently good throughout the entire pregnancy, I think, again, you use the term into the wild. I say you're like a regular civilian. That's kind of what I say.
Yeah. I just wonder though, if this is did the person mean any extra test during the pregnancy or after birth? So I'll answer both. Other than the echo, there are theoretically no other tests. Right. Once you're pregnant, theoretically, you're pregnant, assuming you don't have any other confounding factors, high blood pressure, diabetes, a unicorn uterus, twins, things like that, where you might need other tests. Assuming that you are regular average person who doesn't have any other issues, you don't need any other tests than the 12-week ultrasound if you choose to do it, the anatomy ultrasound at 18 to 20 weeks, the echo at 22 weeks of the baby's heart, and that's it. Now, in many urban settings like ours, many of the patients end up having growth ultrasounds every 4 weeks to continue to watch the baby's growth. That is not part of the recommendations. In fact, I think the recommendation might say a 32-week ultrasound, and that's it. But I would say that the majority, if not the vast majority of our patients want to do it. And so we don't say no. I'd love to say no harm. The truth is there can sometimes be harm, not in that ultrasounds are harmful, but that knowledge can be wonderful, but it also can be challenging.
Anxiety.
Right? As Katie might know, we sometimes see things that clinically mean nothing, but now we have to mull over, should we do something? So we have to be cautious with all of these little interventions in reminding ourselves that I'm a huge fan of, like, this is going to comfort us, but we have to remember there's a flip side to all of it. But as far
I thought of one intervention, Shiva, actually. Yep. So there's been some newer guidelines that came out from the Society of Maternal Fetal Medicine Specialists that suggest that if you have any risk factors for gestational hypertension or preeclampsia, you could go on a baby aspirin from 12 weeks onwards. And on there are many things that do apply to our patients. So they could be age 35-year-old or greater, BMI over, I think, 28 or 30. And then some publications have IVF pregnancy on there and some do not. So a baby aspirin from 12 weeks onwards towards delivery might be a specific intervention that your OBGYN might want you to do.
Right. And that's such a good point. So just to reiterate, because we're consistently trying to decrease the risk of preeclampsia, which is when you develop high blood pressure towards the end of the pregnancy, they've really done great data that baby aspirin, low dose aspirin, in certain situations will really decrease the risk. And ACOG initially said IVF, but SMFM's guidelines didn't say it. And now I think that they've just changed.
I think ACOG doesn't have it, but SMFM does now. I think it went the other way. Yeah.
And we should say, you should all talk to your doctor about it, but it is not just IVF. It would theoretically be 2 risk factors. For example, like Dr. Hurwitz said, if you have IVF and your BMI is over 30, if you had IVF and you're over 35, if you had IVF and you have a mother or sister who had a history of preeclampsia, or IVF with, for example, twins. So there are certain risk factors for it that you can take a low dose aspirin, which is a very, very safe intervention that is very widely studied. Many of us joke that we're going to start putting into prenatal vitamins in the future. But as far as the delivery, the next question was, are IVF babies usually early? And if so, why? No. I mean, again, assuming the patient comes in with no other risk factors, right? If the patient has had a history of preterm deliveries or a history of a uterus that might have a different shape, then she might go into labor early, but that's not the issue with IVF. That's just the people who are potentially getting IVF.
And those risk factors would be the same had she conceived without any treatments. Yeah, exactly.
And nor do you need to be induced at 39 weeks merely for IVF. Now, again, we know that many patients going through IVF might be over 35 or even over 40, and the guidelines are supportive of inducing women at 39 weeks just to reduce the risks that occur after 39 weeks. But it's not a hard, fast rule that you'd have to be induced at 39 weeks or deliver early.
Yep.
Yeah.
Yeah.
Katie, can I ask you a question?
Yeah.
Katie, can I ask you a question? So knowing us both and being in both practices a couple of times now, is there anything that you've noticed in the transition that would have been helpful for you to tell patients out there, or that you want to get out or have us debate?
Honestly, I think that I think it was you, Dr. Gofrani, who mentioned this, is like, I felt really empowered coming into your office with that physical, those papers that I like handed over to you. And I'm like, here's my stack of records from from the fertility clinic. And, and also just being able to have that, that conversation with your doctor ahead of the actual exam. Like, I remember, sitting in Dr. Gofrani's office, and before, we did an ultrasound or anything like that, we went over everything in that packet. And I wanted to, I'm one of those people who are very thorough with like making sure, everything about my past and, all my questions and concerns. But it was really great to have that kind of like that reassurance that you have everything that you need. And also because, Dr. Gofrani referred me to Dr. Hurwitz in the beginning, I know that there was that relationship there, and I trust both of you, you know what I mean, to kind of make sure that all the check boxes have been checked. And yeah, I think other than that, it's just like advocating for yourself too. Like if you have any questions or concerns, or, I want to make sure that, they know about my history of miscarriages and when I miscarried and, so on, what medications I was on for how long. I think that for me, it's like the details around everything. I really like to know that my doctor now knows that. And I think we do a really good job of, making sure that transition is as, seamless as possible, and to which eases the worries of that patient going, back to the OBGYN. So yeah, with that said, also, I wanted to just make sure that everyone knows that I have been taking baby aspirin my entire pregnancy this time. So I advocate for that too. And also as an IVF patient, but I think Dr. Gofrani, you were saying this too. With my first pregnancy, I did have a scheduled C-section due to my uterus abnormalities. And then I did, because I have a unicornuate uterus, I did go into labor at 38 weeks. It was a great delivery, but again, it was more because of what, my anatomy was, not because of, I was an IVF patient. So just kind of a personal, note there.
Yeah. And actually, I want to point out something that I think, and Josh, I don't know if you're going to agree with me on this, so I'm curious. And again, I say this mostly for the people who are outside of our practice, right? Because I think the people in my practice or in your practice do feel like we've talked to them a lot. But I know that there are people coming from all over the country, and those doctors care just as much, but they may not have the same amount of time or setup or anything. I don't know if this is comforting, but I'm hoping it is. Again, let's assume any one of you, let's say Katie, you came to me and I knew nothing about your miscarriage history. The good news is I could still take care of you, medically speaking, just as easily and just as well. And again, I say that because I do think it's very appropriate and easy for patients to think, I want to go back to that doctor because they know everything about me and they know, or I've had patients say like, I want you to be the one to do my next surgery because you know what it looks like inside. Listen, I'm thrilled to do your next surgery because we have a good relationship with our patients. But the truth is you could go to any doctor without even knowing your history, they can still take good care of you. Now, the art of medicine, I would say, is because I, for example, knew your history and knew what you had been through, and we had been through that together, it provides a certain amount of comfort. And I think Josh and I feel very strongly that medicine is not just this mechanical, like you are a vessel and I will take care of your vessel, right? It's not that. But again, I play that fine line between both, because I think for many women throughout the country who don't have access to a doctor that they maybe do feel emotionally bonded with, I don't want them to feel that their actual medical care, if we look at medical care as just the physical aspect of it, I don't want them to look at it as being altered or less. I do think that medical care encompasses the emotional side. And I think that's really valuable. But I feel for people throughout the country who can't necessarily find doctors just because of the access. There's not as many doctors in a lot of the parts of our country, right?
Yep.
Yeah, well said, Shiva. Yeah, well said.
Yeah, definitely. We got another question, and this is just a clarification. So can you clarify, is the echo scan just for IVF patients or for all fertility patients? And I think you said it was just for IVF patients, correct?
Yep.
Yeah.
Right. Meaning not, if you've used oral medication or injectables or insemination, you do not need it. It's only for IVF. There are other reasons, by the way. Now patients who are taking, for example, SSRIs, Prozac, Lexapro, those medications, which is very common, and we have a lot of patients taking it with very good reason, and we would never take them off of it. They're actually now recommended to get an echo. Or if you've had a family history with any cardiac anomalies. In fact, they're also going to start adding higher BMIs. So if you are ahead, there's a lot of reasons to need it. Which good news is it's often just it's just a precaution, just so we know what is happening for the rest of the pregnancy as far as the baby's heart.
Yeah. Good point. Yeah. All right. Well, we're gonna we have one more question before we wrap tonight. So for both you, Dr. H and Dr. G, what do you want patients to know during the transition period? Kind of just to to ease their worries, just from like a overall supportive factor.
I'll tell you what I say to every patient when they graduate. You ready? I say, guys, I always knew you were going to get here. I know you're going to do great. And this is graduation, not goodbye. We'll always be in each other's lives. And I'm so happy for you. And I want them to feel that love when they graduate, because we put in all that work when they graduate too,
Yeah, I remember you saying that to me back in February. Yeah.
It is so fun to deliver a baby and be like, can I call Dr. Hurwitz and tell him that you had the baby? And like, I'm gonna call him.
I actually saw a picture of a C-section that you did last week, by the way, just so you know. You were in the picture holding the baby.
You did.
Yes. You were in the OR holding the baby. I don't know how they got a picture in the OR, but I have it.
Oh, we take pictures in the OR all the time. No video, pictures. I would say, Katie, kind of like before we started, Katie and I had a long talk as two people who know each other professionally, but also personally, both have had miscarriages, and I said, God, don't you wish that we could really impress upon every person when they're about to embark on this pregnancy journey, all of the what ifs without it being scary. I always say that I want to be able to say to every woman, by the way, when you're going to start having sex, you might be exposed to HPV and herpes. And by the way, you might have PCOS or have endometriosis or go through miscarriages. But I don't ever want it to be scary. I want it to be like, these things are actually really common. When they happen, please do not feel alone. Please do not feel scared. Because I think the worst part about, for example, having a miscarriage or not getting pregnant is that somehow you really believe that you are one of the only people going through it. Not from an ego perspective, but just because we don't talk about it enough. And you have that fear that it means you're never going to mother. And the data actually says what? I think, Josh, when someone has a miscarriage, 95% of people will then go on to get pregnant. And
even if you have 3 miscarriages in a row, the very next pregnancy,
you're still likely going to get pregnant. Yes. And so I think that what we can really say to women is, you will mother, whether it's, again, spontaneous pregnancy with or without miscarriages, or oral medication, injectable medication, IVF, donor egg, donor sperm, adoption. There's so many different ways. Yep. That's hard to hear in a way because you don't want to think of all those things. But the truth is, if we start with that without it feeling shameful or anxiety provoking or fearful, then I think we would all be calm. I mean, I think as women, and Dr. Hurwitz, you'll never understand, it's not your fault.
I'm highly estrogenized. No,
I know you are
very highly
estrogenized.
estrogenized.
But this is something you won't understand. I think that women all agree that you live your early years being really worried you're going to get pregnant. Then once you're ready to get pregnant, you want to be pregnant immediately. And then every month you look and you're like, why am I getting my period? I should be pregnant. Then you finally get pregnant. Maybe you've had a miscarriage. Then your pregnancy itself might not be so easy. Then everyone's focusing on your delivery and is it going to be vaginal or C-section? And then there's nursing, and the entire situation, as beautiful as it is fraught with so much anxiety, all the while that you are trying to like be a daughter, be a sister, be a friend, work, be a wife, all the things, right? It really is a magnanimous, absurd amount. And so I think what I want everyone to know is that as amazing as it is, please do not feel the pressure, especially when you're a fertility patient, to then think that every single second afterwards has to be so precious. I think there's a lot of pressure on women who've gone through IVF in particular, or any fertility issue, miscarriages. Once they have their baby, everyone's like, well, this is what you wanted. And you feel this pressure of like, I can't complain. This is all I ever wanted. But in that moment, your baby's still crying. And your baby just like vomited on you or like shat on the floor. And I want to give every woman permission to say, it's okay to actually still be sad about those things or mourn the loss of your prior life and still know that pregnancy and deliveries and mothering is miserable and magical in so many ways, like everything in life. And that at the beginning of your journey, it might be really hard, but you're going to end up most likely being a mom. And, we can certainly help make it less anxiety provoking. And by the way, that's what Tribe Called V is all about. Tribe Called V. Trying to debunk all that. So
absolutely. And actually, so I just wanted to wrap up with Dr. Gofrani, like how can we learn more about your work and where can we have folks contact you? Tribe Called V.
Tribe Called V, where we have, we really try, we say we want to increase your knowledge to decrease your anxiety. We want to give preemptive knowledge. I mean, in an ideal world, I would teach women and people with vulvas and vaginas all of this stuff before they're going through it, so that they could be like, oh yeah, wait, I heard about this. It's still stressful, but it's less stressful than having to backtrack and then learn about it. That would be ideal. So tribecalledv.com, or I'm on Instagram in my own Instagram, or Tribe Called V's Instagram. That's it.
Great.
Yeah.
Great.
Yeah. Ton of information on Tribe Called V. Everybody should check it out.
Yeah, definitely. Yeah. And obviously we can find you, Dr. Hurwitz, at Illume Fertility. You can visit us on illumefertility.com. We have a ton of ebooks and other resources, blogs. Dr. Hurwitz, you're one of our most popular features on our Instagram account. I would like to get that.
Oh boy.
He's very popular on our reels. So yeah, is there anything else that you both wanted to say before we wrap? Are we all good?
What a lot of fun this was. What a great group of people. I appreciate that all these people signed up, sent in the great questions. And just remember, the only thing we can't fix is if you're not seeing us, right? Don't be afraid. Don't be alone. Come on in. The hardest thing I find that patients have to do is just walk through my door. That could be on Zoom, but just walk through my door for the first time. And then they feel the love. And then they know what's going to happen and they know which direction they're going to go, and they're going to graduate back to their great OBGYNs like Dr. Gofrani and others.
Yeah, absolutely. Well, thank you both for joining us. This was a really fun conversation. And I'm so glad, I'm sure that, I learned even a lot, even, going through this twice. And yeah, well, definitely anyone who has been on this Zoom right now will get a recording of this Zoom, and then if you happen to miss it, we will also have it on demand as well. So thank you both again, and hope you have a great night.
Thanks for having us.
Don't forget, Katie's journey is also on our website. You can actually see her journey through. It's really been a really fun ride to see it from your perspective, because I know what it's like from my perspective. So I think it's been fantastic.
Yeah, it's been really cool sharing it with everyone. Obviously, I'm fortunate enough to be a patient and an employee here. And it's been a really, really exciting journey, and the support that we've gotten from the Illume community and everyone that follows us has been really awesome. And I'm super grateful for it. So I'm glad to share.
Good night, everybody.
Good night.
Thanks.
Bye.
Bye,
Bye, friends.
Bye. Bye.